Hello and welcome to Nursing Notes with Mark and Daniel. I'm Mark.
And I'm Daniel, and we're here to discuss death and dying today and all that entails.
Yeah, Dan, you know I have been dying to talk about this.
Absolutely. And it is a bit of a morbid topic, so we figured we'd start you off with a little bit of a joke. There is a PowerPoint online that goes along with it, so it makes a bit more sense if you see the picture. But, you know, the old song, the patient died by playing the funky music too long.
Play that funky music.
Yeah. But back to the original topic itself, there are a lot of things mentally and physically that are of concern to our patients when they're approaching that final phase of life. So, most rudimentarily, we define death as a cessation of all vital life functions within a patient. Now, you may be asking yourself, what does that mean? Because vital life functions can vary from person to person. Well, they usually can define it by a cessation of breathing, most obviously, a cessation of the heart, so when you're checking for a pulse, you're checking if the patient is dead or not, or a cessation of brain function. And there are all specific machines that can test for these, but that's the closest thing we have to a diagnostic test for death, other than just visually observing that someone is dead.
Right.
So
basically, they stop breathing, they stop, their heart stops.
Yep.
Doesn't come back, and then there's the brain dead part, right?
Mm-hmm.
So.
And we did look online for any sort of time frame as the patient would be defined as clinically being dead or dying, and there's no specific time frames for the most part. Depending on what care you get, there may be certain time limits and such, but there's no like time requirement for someone to have not breathed to be considered dead.
Right.
They kind of just go until there's not much of a chance of the patient going back. Like you'll hear stories of people doing CPR for 10 minutes or an hour and the patient can come back. So it depends on the person, so there's not really any specific standard. But in the case of practice, it is the physician's job to pronounce someone's death.
Yes.
So we as nurses probably won't be doing that.
Right. And as you know, you'll keep doing CPR until somebody finally steps in and goes, that's enough, we're calling it. So so there's a couple things that go on with death and dying. So that's the death part. So the dying part, obviously we as nurses know, most of the time it's some kind of chronic illness, correct? Maybe they've been terminal cancer. So what things happen with chronic illness? Well, we have a few things that happen. So once diagnosed, we have a few components. We have the psychological component, and then we have the physical component. And so as we move into those components, some of the few things you might want to think about is they'll present with maybe weakness as they get closer towards the final death phase. Their pain decreases, actually, their sensation for pain. They'll present lethargic, right?
Mm-hmm.
So
you'll see them withdrawing from social activities and things like that as they approach their death phase.
Right.
It's kind of like one of the biggest indicators for death is when you notice these really strange behaviors out of somebody, because oftentimes they can sense their own death.
and that's the pre-active phase, actually.
Yes, so there are going to be two phases when a person is actually dying. There's going to be the pre-active phase, which is kind of like the precursory phase, where you start to notice like,
Oh my
hey,
God,
this patient's not doing okay, maybe we should investigate a little bit more. And then there is the active phase of dying, where the patient is on death's door and it's clear to pretty much everyone that they don't have a lot of time left. And as Mark mentioned, it is a mental game just as much as a physical one. So a lot of times the borders between the pre-active and active phase aren't very clear. And as a nurse, there are just a specific few symptoms that we can look out for, and Mark will tell us.
Yeah, actually, and so what happens is that you might see when someone initially gets maybe into a terminal illness, you'll see things like social withdrawal. They'll start to tie up loose ends. I need to finish this, I need to do this. A high anxiety component starts to kick in. They start to lose interest in living or doing things. They don't want to go out anymore. They want to stay in their house. They have you'll see also on the physical side of it, they start to have decreased healing issues. Ulcers start to kick in. There's impaired nutrition. They don't want to eat anymore. The biggest thing is they'll come out and say, I'm going to die. They start verbalizing, I'm going to die soon. Those kind of things. And then the biggest thing is you might see an appeal to religion. You might start asking to go to church a lot or see a clergyman and those kind of things.
Basically, it's one of the good things to remember is that as they're dying, they start to do a lot less with themselves. You'll see them do less socializing, less eating, less general moving as they become closer to death's door. And those behaviors are kind of like a warning flag for us as nurses, so we can start to prepare the patient for end of life, especially from the mental sense, because it's very stressful. And mentally, it seems like one of the biggest parts of death, because the patient has this dread feeling that they're going to die, and we have to be able to manage that as nurses. But moving on from that, there is also the active phase of dying, where the patient is very close to death, and some of the symptoms most prominent to that phase are when the patient vocalizes and they say, "I am going to die soon," and they will physically confess to you that death is approaching, because they know a lot better than we do most of the time. Other things are dysphagia, so the patient has a lot of trouble swallowing and eating, kind of a intensifying of the problems from the pre-active phase. Again, moving from lethargy in the pre-active phase to total unresponsiveness in the active phase of dying. So you'll go from someone being just generally withdrawn to being unresponsive, and they'll start even saying incoherent things and psychologically having a lot of difficulties. This inactivity becomes a lot more pronounced as the active phase continues. And one of the last things to look out for if somebody is very close to death, like immediate, would be acrocyanosis.
Acrocyanosis. Everybody say that with us. Acrocyanosis.
It's a big $10 word for when your hands and feet become cold, blue, and sweaty. And that shows that the blood vessels in your extremities are closing off and blood flow is decreasing, which means the patient is very close to not being alive.
And then once you get to that point, and sadly, they're, moving to another level, there's not really any diagnostic tests that you can say, oh, let's test for death.
Yeah.
They're either not breathing, their heart's not beating, or, now granted, you can maybe use an ECG as they start to get closer and see if there's brain death, but 9 times out of 10, you just can't do it. So absence of pulse, absence of respiration, and no brain function, death. So that's your,
and then for dying, you just have to look out for those symptoms. There's not really a test for it. It's more of a quantitative acknowledgement that things are changing for the person. And if there's no clear cause why, death may be a particular thing. Right. So moving on, some of the things we can use to treat death and dying in a patient, which sounds kind of counterintuitive, right, because if you think about it, the entire nursing process is to prevent death.
Correct.
But at the end of the day, it's something we can't avoid. Right. So when it is inevitable and we know that the patient is headed that direction, we can do hospice care, which will help make the patient comfortable for the end-of-life experience. We can manage pain, and that's a lot of what hospice care centers on, is rather than curing the illness, it's just making the pain go away. And instead of making them feel better, making them feel okay as they pass off into the next life.
So a quick note about hospice. Most of the time for somebody to go into hospice, they have to have a life expectancy of basically about 6 months. We've done everything we can do, and it's only based on making them as comfortable as possible until the time comes. Meds will be used. We'll get more into that a little bit later, but emotional support, and then in the final phase that hospice does is bereavement support. So once
and what's bereavement again, Mark?
Bereavement. Well, there's going to be other people in this class talking about things like that. And that's like Christ dealing with how you deal with death, how to handle it during this time frame. So we're going to move on from that.
But from a psychological perspective, grief and bereavement and death are very, very closely linked. So a lot of the same things you would do for grief and bereavement, you would do for death.
Right.
But we're not going to go into that
because you're going to get more on grief and loss from someone
Absolutely.
else.
But the next thing we do for the patient would be pain management.
Correct.
And namely, this is going to treat all kinds of pain within the patient. That's going to be physical pain, somatic pain, visceral pain, and neuropathic pain. Which visceral pain is going to be the interior pain that's like a sharp stabbing motion where you got like punctured by a knife. Somatic is kind of just like generalized pain, like, oh, my tummy hurts. And then your neuropathic pain is going to be things like fibromyalgia and things that don't really have a definite cause. Radiating is a very good word for it. And we're going to use a lot of medications to treat this pain normally, but you can also use therapeutic things like massages and other pharmaceutical solutions to pain. All is fair game, and it depends on your specific patient what you're going to use. But some of the major medications we're going to use, I should clarify, there's actually 3 phases to hospice medicine treatment. The first phase is going to consist of your NSAIDs and your acetaminophen, where you're just using generalized pain medications to treat generalized pain.
And then let me just jump in. Stage 1 is basically at that first stage when someone's just beginning their chronic illness disease. They may not need those massive painkillers that we all often think about when people are in death phase. So.
Yep. Moving on from that, we have stage 2 where the problem would worsen and traditional medicines seem to be doing less and less. So we would move on to something a bit stronger, which is going to be an NSAID, usually paired with a higher or a low dose opiate. Namely, one of the biggest examples of this would be Tylenol and Percocet, which Tylenol is not an NSAID, but it's commonly used in this role. And finally, in stage 3, where the problem is as bad as it's going to be, we switch to high-dose opiates. So that's going to be your morphine and anything else that helps ease the patient's pain, but it's a lot higher dose than the second stage, and it's going to be a lot of just general comfort care. So,
and we all know from last semester that your Tylenol is liver functions, and your opioids are always going to be decreased respiration, constipation, those kind of things. You can always look back and go, okay, I know I can look up morphine, but being that they're high prominent known drugs, most of the time these are the prominent ones you're going to see.
Yep.
So, and like Daniel said, Tylenol's not an NSAID, so remember, the only difference that Tylenol does, it doesn't have the anti-inflammatory component.
And remember, you're not going to exceed 4 grams of that a day because it can really impair liver function. As opposed to your NSAIDs, which are going to affect kidney function more so, but they can also induce gastrointestinal problems. So you always want to take an NSAID with food, just as a reminder, you know. And back to the opiates, that's going to be your things like morphine, Percocet, fentanyl, etc. Decreased respiration, constipation, and a bit of wooziness from your patient. So don't let them operate any cranes while they're on morphine.
That's correct.
So that would be the general medicine care that we would offer to a patient, but all of nursing is geared to curing dying, so there are hundreds upon thousands of more medications that we could mention here. So we just decided to stick with some of the main ones. We also should mention that antidepressants can be used during nursing
and
care.
Probably will be used. So.
Absolutely, because we're fighting those psychological issues, and some of these antidepressants can also relieve some neuropathic pain. So that's going to be things like your clozapam, something like that. I'm not sure of the exact name.
Yeah.
Yes, but those are going
Valium be used.
Yeah. Yep. But those are going to help ease some of the patient's neuropathic pain. Some of the things to watch out for when a patient is on antidepressants would be decreased CNS function. So just mental lethargy would be a good way to describe it. They're a lot slower to react, and there can be rare and complicated side effects, like serotonin syndrome would be a big one to watch out for, where the patient goes into a medical crisis due to an imbalance of serotonin in their brain. We also want to look out for just decreased motor function as well. It can also harm your muscles. And those would be the main primary medications that you're going to use in hospice type care. A final thing to consider would be therapy, and Mark actually has a degree in therapy, so I'll let him talk a little bit about some of the things we do for a dying
And actually,
person.
the therapy we're talking about is not actually sitting down and going, so how are you feeling today? The therapy we're mostly concerned with is, again, it's going back to how do we ease the pain and make them as comfortable as possible in the dying phase before death occurs. And so, again, we're back focused on the chronic illness stuff. So the key that we're going to talk about is just minimal stuff, because again, someone else in this class might be talking about grief and loss. And the grief portion of when someone starts to go into the dying phase is a big component. So the things that we're going to probably do is just basically comfort measures, social interaction, and helping them with daily life. Because as people start to digress, as nurses we know, you're going to have to feed them, you're going to have to wash them, you're going to have to basically care for them 24/7. But the big component is as much as social interaction you can. Bring in family members, friends, music, television, even just sitting and talking with them, even sitting and being quiet with them. Hold their hand, and who does not like the back rub? Actually, I could use one now.
Yeah, my shoulders are a little bit sore. But moving on, Mark brought up a really good point, is that this nursing care focuses on the patient just as much as it does their family. Because if death is inevitable, it's a matter of preparing them for what's going to happen. So you might also be looking at things like a social services consult to help finish those end-of-life estate deals and financial concerns if they have no idea what they're doing. And just to make sure that the family and person understand what's going to happen. Because if death is inevitable, it's really interesting to watch the focus of nursing shift from curing the patient to making them feel better.
And there you have it. So
Yep.
here's another, look for another episode of Nursing Notes with Mark and Daniel. And
Yep.
One thing I heard a long time ago, in the game of life, nobody wins. So live it.
Yep. Another quote I heard, just as a final closing note, don't fear death. It's the stake one place to play the game of life. So thank you all very much for your time, and I hope you have a good rest of your nursing life.